Hello and welcome back to the Advancing Healthcare Innovation Show. I am your host, Michael Stamatinos. And if you're new to us, we are super excited to have you here. Welcome. We're bringing really exciting conversations with phenomenal leaders in healthcare that are painstakingly reshaping the future of care. And we happen to be crazy passionate about a few different areas. We're passionate about access, we're passionate about leadership, we're passionate about innovation. And if it's your first time tuning in, let me just sort of take a quick step back and tell you a little bit more about what we are trying to do here. So we're focused on bringing real stories of innovation within our space to life. So the aim is highlighting real people that are actually getting stuff done and giving them the opportunity to share their story with our community and ultimately with the world. So we've got an amazing action-packed year. If you haven't had the opportunity to check out any of the historical interviews, however you're consuming this content, whether you're watching it, whether you're listening to it, please hit the subscribe button now so any new interviews come directly to you. So really excited about this conversation. Every now and again, you kind of meet someone that reminds you about what this whole thing is actually really about. It's about helping people. And John Wadsworth is one of those people. He's the co-founder of REDi Health Analytics. And he spent more than a decade at Health Catalyst, helping health systems across the country make sense of their data and turn it into action. But before that, he cut his teeth at Intermountain Health, long before data-driven became a buzzword. And I think what I find most compelling about John's work is who he's choosing to serve and who the company REDi Health is choosing to serve. Rural hospitals, community providers. I mean, the places that really the weight of care with limited resources and like no safety net. So he and his team, they see what's happening inside of many of these systems, and they're helping fight denied claims, helping folks strengthen their finances and create visibility that actually leads to better care. There's a line that I'm in researching, for this particular conversation that stuck with me that John had mentioned. So the amount of innovation in rural healthcare it's actually staggering once people understand and trust their data. Like that's it. That's the unlock. And when people trust what they're looking at, transformation follows. And for me, it seems like that's the mindset. That's a little shift, that the 2 millimeter shift that sets things apart. And John seems to me that John doesn't just see numbers, data as numbers or numbers on a dashboard. He sees it as stories. And that's what I really want to unpack today. Stories that reveal where care breaks down, how it can come back together again. So today we're going to kind of dig into his story, his journey, what he thinks about access, alignment, and impact. And more importantly, how he's helping rural providers go from surviving to leading. So John, it's great to see you. Welcome to the show.
Thank you, Michael. It's fun to be with you today.
Yeah. So listen, before we dig into REDi and transformation programs, just sort of take us back for a second. Where did this passion for rural health start? And was there like a person or a place that made you see healthcare differently?
Boy, it goes back even before rural. I call it the Wayne Cannon moment. I was a young data architect at Intermountain Healthcare right around 2002 and building registries on chronic conditions for the primary care clinical program, about 325 providers that we were doing diabetes and asthma.
Mm.
There was this national movement to try and integrate mental health, getting that data and substance abuse data on top of these chronic condition registries. And this was the moment that galvanized, I got to spend the rest of my career in this space. I sent a report to Dr.
Wow.
Cannon, and he was a pediatrician, and it had one 11-year-old girl that was on his panel. He knew she had diabetes. He treated her for diabetes for 3 years. He had no idea she had depression. And
Mm.
when I sent this report to him by integrating mental health with that, he brought me into his office and he's like, how in the world did you identify that she has depression? I could just see, because we were grabbing claims data, she was going out of network. And
Mm.
he teared up. This is 2002. He teared up in his office and he said, this fundamentally changes the way that I think about care. I had no idea that I
Wow.
couldn't manage her diabetes because she had these flare-ups and depression as an 11-year-old child. And at that time, I thought, this is exactly what I want to do, and got to do that with Intermountain, like you said, for a decade, and then with another publicly traded company. But the idea for REDi came after this company went public in 2019, and we realized, oh my goodness, so many of these really small systems are finally getting
Yeah.
their first digital record, and they have no idea how to use that data. So that's where my co-founder, Jeff Grandy, put his arm around me and said, we got a mission to fulfill. Let's scale this down in a pragmatic way and go do this for rural.
Mm. I mean, in terms of rural communities, was there always the idea that hey, we have to if we want to go fast, we got to strip things down and we got to take it down to the bare essentials. Was that always sort of the idea that you needed a different approach to tackle this particular segment?
That's a great question. I think we realized that the scale had to come way down just because they didn't have the resources. When you go from supporting big systems like an Intermountain, these massive
Yeah, yeah.
IDNs, to, okay, this is an 11-bed hospital in rural Utah. Like, there's no analyst there. They've got someone who might understand the electronic medical record, but it's really a director of revenue integrity, maybe one of the administrators going, help us make sense of our data. So I think we came in with that mindset that we've got to find a way to scale it down. We just had no idea how limited their availability would be. That was one of the biggest barriers, is you can't take them offline more than an hour or two a week. That's it. They've got 6 hats they're wearing, and we were
Hmm.
accustomed to working with dedicated change management experts and technical experts. And we walked in thinking, well, where are they? Well, they're not here. That's part of the mission and the evolution is, well, we got to find a way to bring those competencies in that 1 to 2 hours a week that they have available.
Wow. When you mentioned the story about the patient that had depression, was that the moment that where the data made you actually feel something, where it connected
100%.
back to people and it wasn't just about performance metrics, like this is about people.
That was an actual person who was not getting the right diabetic care. And it totally coincided when she would have depressive bouts. And you could see the PHQ-9 score spike, laying that on top of her hemoglobin A1C levels and not managing with her parents. That's where it galvanized for me. Oh my gosh, I've got to be in this space and surrounded by people who do this even better than me.
Hmm. I mean, because you had a couple of really nice tours of duty, 10 plus year stints, prior to starting REDi Health. What do you feel like was missing in the way that healthcare was sort of serving these rural communities?
Well, I mentioned that these small systems were finally getting their first digital record. And I think what we realized, what we didn't know in 2020 was, okay, well, we're just going to go do this. It's just at a smaller scale. We're going to have those technical resources that we're accustomed to working with and drive that innovation. And after a year, we realized there are no analysts embedded in these systems. In my 5 years of doing this with REDi,
Hmm.
this isn't a criticism. It's an interesting data point, Michael. I've legitimately met two healthcare analysts that are actually in rural healthcare inside of a hospital system. Contrast that
Good.
with my role at Intermountain. I was one of 400 analysts at the time, or data architects or medical informaticists. 400.
That's wild. That's really wild. All right. So then if you think about the timing of this conversation is really interesting because there's this little thing called the Rural Health Transformation Program, and it's giving small hospitals a chance to kind of really reimagine care delivery, maybe new payment models, new infrastructure, new partnerships. From I'm just sort of curious from your perspective, what is the biggest opportunity in that shift?
I think there are a few things in here. One is um, people need to realize that while there have been dollars that have come into rural, those have been more like the provider relief funds. Take it and use it
Mm,
however you're in tune acutely with the pains in your system. So take it and spend it on that. This is different. The order of magnitude difference in the volume of dollars that are coming in has attracted a
Right.
lot of new players, but also that the transformation as part of that term rural health transformation program, the feds are serious about this. Like they want to see at the end of the spend of these 5 years, could you actually document that you are better off, that you have a sustainable path for financial viability, that you've actually improved access to care and services that weren't there before you received those funds, and you're doing that in a sustainable way. And on top of that, if you can achieve those first two, kind of the pie in the sky is let's drive better clinical quality outcomes. The big systems have been doing it. If we put this money into it,
Right.
you should be able to achieve that too.
Hmm. Is there like where do you feel like leaders are getting caught up in the noise? Is there a difficulty in them trying to sort of narrow down and focus? So obviously there's a lot of things that are coming at them. And I'm just sort of curious from your perspective as someone that was an insider who's now gone to the outside to try to disrupt going from the outside in. How do you level with them? How do you get them to sort of filter the noise?
Boy, another really good question, Michael. I think, again, this isn't a criticism, it's an observation that I think so many that are in rural just haven't experienced the value of what iterative real analytics can do for their nuanced needs. They've never had that benefit. And so when you have this application process for every state going, hey, tell us your needs. We got these listening sessions. This is great. Come tell us. Well, they're coming with that perspective. I don't know what I don't know, but I know that I'm struggling to keep my doors open. So maybe you could help
Mm,
us increase this service line, or we've always wanted to start an oncology or a dialysis program. Well, what evidence do you have that at the end of 5 years, you actually have the volume to justify that? And there's no data. They're really good operating from a gut level, but I think that's where they're probably struggling is this data literacy is pretty low, and they
mm.
want to get there, but they want data that one they can understand and two they can trust, and they want it timely, that it's relevant for their system.
So,
A common,
so, so when
yeah,
you
go
say
ahead.
low data literacy, I mean, how big is that gap? How big of a gap are we really talking about here?
Massive compared to the large systems. That's probably one of my greatest motivators and the biggest pain that I feel is I wish we could go faster because we've seen the value of what data can do for big systems, for payers, and these small systems. I mean, many of them didn't even adopt their first medical record until 2015, 16. Well, the
Mm,
HITECH Act was 2008 that subsidized
yeah.
Epic and Cerner and all these big systems going, great, we're digitizing based off work coming out of Intermountain and other systems in 2000, 2002. So they're 15 years behind in the adoption of their first record. Think of the evolution in big data and data warehousing
Yeah.
for 15, 20 years. They finally get their electronic medical record. Now you don't have any technical support behind them. They're going, what do I do with this data that we're catching? And how do I start integrating that with my payers? That's where I think so many of these administrators are struggling, going, well, how do I participate in this rural health transformation program? All I really know how is represent the needs that I've done in the past, but I can't really envision something different, with maybe a few exceptions like, well, I need some AI. I need
Right.
some new widget or some new tool. And
Mhm.
I just, I call me biased because we're on the services side of things. I see kind of an oversubscription, if you will, to the
Mm,
technology in rural and a lot of tools that really aren't plugged in yet. They bought
mm.
them and they're not sure
Yeah.
how to integrate that in with their package. So you're oversubscribed. Let's make sure you can leverage what you've already got before you go out and buy more.
All right. So when you help a hospital see their data for the first time, what what emotion do you watch for in the room? And do you have any maybe stories that you can share about that?
Yeah. Do you want me to name names as hospitals here?
It's your episode. You can do whatever you want.
There's one that it probably is the embodiment of what I hope people kind of take away here. It's such a message of hope. There's an 11-bed facility in Blanding, Utah. It's called Blue Mountain Hospital. We came in with a grant from the state, so totally funded by the state. And as busy as they were, we sit down with this director of revenue integrity, and after 2 or 3 weeks of showing her examples of data, asking for her, you tell us what you need, she finally said, I don't have time for this. I'm sorry. So she kind of gives us the Heisman and pushes us out. Well, one of her business partners is over quality. And so she says, maybe you can work over there. In 6 weeks, we built out a dashboard for surgical site infection, tracking every single case of surgery that was coming through there. And across the street, they've got a large Native American population. So there's a lot of collaboration with UNHS at this facility. And we're now catching in near real time through this dashboard surgical site infections they were missing, had never seen before. They're catching that before patients go home, having those conversations with providers, getting them the antibiotics they need and sending them home. Suddenly that quality officer goes over and grabs this director of revenue integrity and she says, you got to give this another shot, but you have to make enough investment each week to really understand the language of this data literacy, because I don't think you gave it a fair shake. And
Wow.
it took someone like that to catch the vision, to put an arm around someone else and say, give it another shake. And when Denise could give us that time, my gosh, the stories
And
that
you
have
said
come out
one
of
to two
it,
hours a week.
1 to 2 hours a week. That's it. So we would meet like on a Monday, pull the information from her head. Okay, what are the things that you think you want to see? We'll build this data model underneath it. And Thursday, we're going to review it. And then the following Monday, and then the following Thursday. So touch points twice a week that you're getting. She gave us another shot. And in that, there are three specific examples I'll give you, just cool use cases. One
Yeah.
was Medicaid, kind of taking this all the way back to RHTP. Everything's precipitated here with massive Medicaid cuts. Well, Medicaid had just gone through an upgrade. They changed their back-end system. And suddenly this little hospital that was getting paid around 81% of contract for build charges, now they're collecting 28%. They couldn't explain it on every one of those Medicaid patients. They're fighting
Whoa.
with the state going, why did this drop? And the state's going, well, we're comping you according to contract. So we did a pre and post analysis prior to the upgrade, same diagnosis, same procedure codes, aggregate that data, took it to the state with them. In 15 minutes, the state said, oh my gosh, our bad. We're sending you back these payments, but in our system, we changed you from a critical access federal designation to a rural. So it totally changes the rates, but they had no way that they could justify and fight that. The state then says, you can back bill us for the last 12 months that we've had this mistake. That was 3 million in back billing, netted them over $1 million just in that one project alone. So you got that.
Wow.
And we go, well, what are you going to do with that? They're like, we're going to keep our doors open. This is fantastic. A second one is in denials, registration and fighting denials with big payers. A registration denial denies the entire claim. And this hospital had never been able to fight those. They're kind of working them on a onesie twosie basis. This is the hospital that has about 17 million in annual revenue. And every year they had almost 600,000 in registration denials. The last 3 months, zero. Zero. We've been able to work with them, show them
Amazing.
exactly the number of times the process works where you don't get that denial, and then elevate that as, here's your gold standard. Let's just do it the same way. But they've never been able to interrogate their data in that way. Those are a couple financial examples and one clinical with the surgical site infection. 11-bed facility in Blanding, Utah.
Well, I'm even just thinking about, the revenue cycle person punching the quality person. They give you a shot, and it's basically you over delivering and showcasing incredible amounts of value. They then kind of come back and say, "Hey, you really need to take a look at this." I'm thinking about this from their standpoint, right? They have so much that's coming at them that sometimes they don't even know what they want to know. Does that mean that you have to go in there with a set of assumptions, or Or do you just sort of reach upon your experience to know, hey, these are key areas that we historically have seen this work really well? Like, I guess how much do you lean on your instincts and your experience versus, really having to rely on a client feeding you what it is that you think you want to know?
Michael, I love the question. And one of the reasons that probably the biggest reason I agreed to come on to your show was the tagline that you shared with me in the first conversation, real people really innovating. I
Yeah.
want to be careful here that we don't overrepresent the innovation that's credited to REDi. I love my job because I get to work with people like Carrie, like Denise at Blanding
Mm.
and that administrative team. Those to me are the real heroes. Those are the ones who are in the trenches, in rural, by choice. And what we get to bring is a complementary set of very distinct skills, but it up levels their role, their understanding, and their stewardship. And once they catch just enough of the vision of, oh my gosh, look how much data we're sitting on that we didn't know you could access because we didn't know how to get to it, they line up with a dozen questions. They're the ones
Mm.
that are the ones telling us, I wish I could see my data in this way. Well, why? And suddenly they unpack, here was this problem, here's this workflow challenge, here's this workaround in the technical tool that we've been using. So I guess part of it is we've done this enough in enough environments that, yeah, there's some lead that horse to water, but there's
Yeah.
also a ton of innovation and knowledge that's locked in their heads. And that's some of the most rewarding is just getting them comfortable. There are no dumb questions that you can ask because you've probably never seen your data quite like this, and certainly not at this cadence. So ask away. What do you wish you could see? And
Mm.
then they just start running with this.
Right.
Then the challenge is focus. We got to get
Yeah. How
we
do we
got to get
know?
a drive to finish something to the end so they see not just the analytics but the change management methodology that goes, you got 5 opportunities. You can't chase 5 rabbits at once. You don't catch any of them. Which one do you want to go after now? How are we going to do it? Who do we have to bring along? And then you scope that and you project manage the heck out of that because they have 1 to 2 hours a week to deliver that value. I asked Denise and Carrie, what advice would you have, even coming on here? And they both said quick wins. It's the iterative quick wins from week to week that you could show us you listened, you asked us questions, and then you showed us a novel representation of our data we'd never seen before. And that kept
Yeah.
the engagement so that week to week we kept coming back. And together they educate us on their process. We educate them on the technical skills.
Yeah. So when you think about innovation, I think when people think about innovation, maybe they picture big city, academic medical centers, et cetera. However, I mean, what's something that you've seen in the rural setting that maybe rivals or even outpaces, that initial innovation that people think about around AMCs?
There is a ton of innovation that comes out of big systems, big IDNs, academic, healthcare systems. The RHTP in particular, because of the amount of dollars and the focus, has suddenly brought new attention and energy from big, I'll call them even benevolent IDNs. And in some of these recent conversations with IDNs directly to REDi, probably one of the most interesting conversations is how in the world are rural independent critical access, tweener, and RHCs profitable? Because
Mm.
we own a whole bunch. We're part of this Rocky Mountain Collaborative. We go to the same conferences, but we're dumping a ton of money subsidizing to keep those doors open. We're dumping a ton of tech through tele offerings, and we're not even close to break even. How in the world do these small systems? Now, there are some that have subsidies, mineral rights, or a county tax, or a tourism tax, but by and large, these are some of the most scrappy, innovative folks going, these are the tools I got to work with.
Yeah.
And boy, necessity is really the mother of invention. It's true. So you see that.
Yeah.
And then we get to be kind of a broker liaison back to some of these big IDNs that are going, on the one hand, I really value this relationship with an 11-bed facility, but the volumes are small. Here's what I'd like to see change. They send patients sometimes way too soon and occupy one of our urban beds. It's a
Hmm.
low acuity patient, but we think we can help them keep that there. Or two, by the time they refer this patient in, That's a hospice patient. It's way too late. These chronic conditions haven't been managed. So they don't like the bimodal distribution. They say,
Mm,
how do we work with them to get a normal distribution? And this is the coolest part of the innovation. For the first time, I'm hearing IDNs now say a rural first lens. What are they doing that we can actually replicate in our systems that we're highly subsidizing right now?
yeah.
Does that make sense, Michael?
Yeah, I know, it's basically you're saying, hey, look, sometimes constraints can lead to some really cool things that you can actually really truly innovate. You mentioned something earlier that just a thought just popped into my mind, but it's really more around trust in the data. Like, how do you get them to shift to actually trust the data that you're showing them? And even getting them to move from, all right, you're reporting on this data to actually then acting on it.
The key to that is listening, truly
Mm,
listening to them. And it's not just what do you wish you could see, it's understanding why is that important that you could see that information. And the follow-up questions of if you could see that, what might you want to see after? And why would that be important?
mm,
That unpacks all kinds of business knowledge about I have this workflow, I'm trying to integrate all these pieces, but I can't do it. And if it could come together, they've already thought through a vision. And that's the pure gold right there is if we can just listen and then iterate from week to week, in these 6 week sprints. Did we
mm,
hear you? Is this what you want? Do you trust that? Okay, now let's go through a validation methodology. We have a whole methodology to validate. And
mm,
what we're really doing in that validation, Michael, is a lot of data literacy theory, but they don't know it. We don't call it that. It's the application of that theory totally nuanced around the project they care about. Registration, medical necessity denials, pre-authorization,
right.
denials by a certain payer. That is how we do this from week to week. They're validating that. We're teaching it from week to week. And then they go, oh my gosh, here are 7 other projects I'd love your help on.
Mm. So it seems like what you're doing then along the way, as you're scoping these out, you're improving their data literacy along the way without them actually knowing that you're doing that.
We started out teaching the theory, thinking we'll just grow this because our mission's twofold. One, it's to turn community data into a local asset, not just hospital, but the community data. That
Yeah.
requires a lot of integrated data. And second, it was to grow technical resources, jobs, create those jobs in the rural communities.
Mm,
But the opportunity cost of trying to grow that organically just through pure teaching, you miss the opportunity. So we provision it, but then we are bringing along basic levels of data literacy so they can expose a lot more opportunity. And then with the savings, they could justify bring in an analyst. We'll train them up right
mm.
alongside you. But that literacy is done iteratively, week to week to week.
Yeah, there's just that cadence, like you said, the week to week cadence. I mean, those that works well over time. Curious, have you seen like cultural patterns, that either accelerate or even maybe even stall transformation, in rural health? I mean, for example, you
100%.
mentioned you mentioned, the one health system where you initially had like a blocker, but then they came back. If you think about as a whole, what do they need to have? What are the ingredients that they need to have in order for something like this to be like overly successful?
There needs to be an openness and some humility at that administrative level. We have seen extraordinary leaders tear down some real barriers. So, for example, one client that we worked with very recently, we were looking at medical necessity denials for imaging orders coming out of the ER.
Okay.
And the coding team, so the provider, you got a physician doing diagnostics, they're justifying, I'm ordering these images so that I can validate and put this diagnosis on this patient, this condition, and then the treatment plan. Once that clinical documentation is done and you read through the clinical notes, there's a handoff now in the workflow to a totally different team, non-clinical people. These are coders. They interpret what that provider has done. They
Yeah.
prepare the information so that you can get a bill and justify the payment, right? So there's this finger pointing that was constantly happening between, hey, I'm making these orders, but they're getting denied for medical necessity. And the coders are saying, well, it's incomplete documentation. The providers are saying coders don't understand what we're putting in. And when you can bring the data in a way that is not threatening, but you can show, hey, here are the rules of engagement from a payer. And if you get
Hmm.
this diagnosis and this procedure code together, they will never deny for medical necessity. Let's look at the number of times, lay that framework on your data. Look at the number of times that happens. Oh, wow, it's only 18% of the time. Well, let's do that 18% of the time, 100% of the time. Then
Hmm.
you're not pointing fingers at providers or the coders. It's what needs to happen from both sides so that we get that outcome that yields not only the clinical benefit, but we get payment for it. And we could not break down those barriers without humility at the administrative level. Because now your admin team needs to come in and go, here's the person authorized from my MDs to
Right.
say, you're all getting on board with this. You're going to do it the exact same way.
Hmm.
It's evidence-based medicine. You guys agree on it, but that one person is in charge and one designee over here on the coding team. Why? You can't take them all offline. There's no way you can get everybody in those work groups. So
Mm.
they have to be the ones to go, I'm deputizing and authorizing and communicating that out through the organization. Bring them together. They do the validation. Now that administrative team needs to say, please bless and adopt these changes they are recommending, and we're going to hold everybody accountable to it. You can't put that on the coder. You can't put that on the provider. That's an admin function. And when
That's
that
right.
culture kind of comes together, it's an alchemy of pure innovation because people feel safe to bring all kinds of things they know are problems in the workflow, but without that transparency and humility, feeling like I might get in trouble if I bring a problem forward. Boy, that's where it doesn't matter how good your data is, you're just not going to drive sustained transformation.
Mm. I'm curious, how far ahead do you look out in terms of maybe even just envisioning how you think data is going to evolve in terms of empowering rural health hospitals, let's say 5 years from now, especially with AI now in the picture? I'm just sort of curious. Tell me your thoughts on that.
On AI in particular, or how far out to
Uh,
see data
I mean,
adding value?
how far out do you think? I mean, are we still really early days on rural health in terms of this transformation that's unfolding, potentially happening? And how far do you actually look out, as an innovator, as someone that's really sees ahead of the curve? Like, how far out do you see?
I think 5 years is probably a really long event horizon with the amount of change that's happening. So I'm going to
Yeah,
just give my honest opinion there.
yeah.
And we've talked about nothing that I think is probably earth shattering in terms of denials or
Hmm.
charge masters, just some basics that big systems have already got a decent handle on, but rural is still struggling. Yeah. But if I think about AI and IDNs, let's take a minute on those two, where I could see
Yeah.
some really cool transformation over the next 5 years. Rural has this fierce independent streak, and it doesn't matter what state you're in. Like those that are still independent, they value that independence from big systems and they
Yeah.
want that. But they've got this odd informal relationship that they're stabilizing patients in their ER every day and then transferring them into an IDN. It's not a great formal relationship. The IDNs are going, you're sending them too soon or too late. And the rurals are going, I hate sending that because I'll probably never see that patient care for this type of patient again on that one.
Hmm.
And they hate seeing those taillights leaving the city or their town to go to an IDN. At the same time, they're saying, I want to grow new services, but they don't have the capital or even the data wherewithal to say, these are the opportunities that we have for oncology, for pulmonology, for cardiology, and to band together in two or three critical access facilities, maybe in related counties or adjacent counties.
Hmm.
Could they do that? Yeah, but they can't do it on their own. This is my opinion. I think we're going to start seeing IDNs more benevolent that say it's in our best interest
Hmm.
because you're within our catchment and you're sending patients to us to use data so that we start better rationalizing the referral process in And it doesn't need to be in an acquisition way.
Right.
It can be, we can help subsidize for a time cardiology in these 3 counties, but I need the volumes and the data. And here's how we're going to leverage tele offerings into your ER and then into the RHCs so that we're elevating the value of identifying those chronic conditions sooner for your primary care providers. And the data can help inform what is the actual consumption of care now, or how latent are we in the identification? So that is kind of the false positive you don't even know about yet that you're going, or the type 2 error. You're saying, I don't even know how big this problem is in our county, but I can extrapolate from those that we are referring
Hmm.
and look at those that are ending up in your IDN based off of
Okay.
claims data that's coming in. So they're going out of network, kind of the diabetes and depression example.
Yeah.
I
Yeah.
think IDNs are going to start biting down on this in a really cool way. So there's that.
Interesting.
And I don't think you have to be acquired for that to happen. In fact, systems like Intermountain have said, we're going to be with Microsoft and Epic, and we're going to invest heavily in this kind of consortium in multi-state to drive
Hmm.
innovation in rural. I think you'll see more benevolent systems that way. The AI side of this, we will see so many of these processes become better defined
Hmm.
and niche tooling that has a total dependency on trusted data models. That's where I think we'll start seeing, as the data models themselves are curated, trusted, and secured from rural, and have the blessing of rural to go, I trust this third party, but I don't yet trust that IDN to have full access to my data. If we can broker those kind of relationships, then I think you'll start seeing AI automate and do a lot of pre-checking. So the denials, the pre-authorization,
Right.
that could not take those jobs away. You go, give those resources back. Now you have a whole lot more resource for clinical. Many of those are nurses that
That's
are
right.
doing this kind of work. So that's where I start seeing AI is limited because it doesn't yet have technical people that can catch it and integrate it. And when they do, that AI model is only as good as the underlying data that is trusted underneath it. And I
Mm.
described at the beginning, there's such a dearth of these kind of
Yeah.
ready technical resources in that space. I think we need a lot more. And as those come in, then you're going to see AI automate, and you're going to see IDNs going, hey, I like this collaboration that's happening here. And now with that partnership of more AI trusted and more IDN benevolence, I think you'll actually see IDN saying, let's test small tests to change rapidly through our rural partnerships. And if that pans out well, then you start adopting that more into the urban settings. That will be a cool shift in
That's
healthcare.
really cool. So let's just say you have the attention of a number of rural health leaders, and they're all in the same room. What's your message to them?
Today,
Sure.
it would be first, a genuine thanks. You're in rural by choice. The I in REDi is inspired. We are inspired because you are here doing what you do. And I would hope they would feel a message of hope. There is so much data you're sitting on today that is underutilized, and it doesn't have to be, and it doesn't need to be cost prohibitive. Um, I would encourage them to reach out immediately to their state offices of rural health directors
Hmm.
and let them know, one, you're interested in participating, and if you don't know how, please reach out to REDi. We have a bottom up strategy. We have submitted a number of applications in a number of states because we've been doing this work for 5 years. Kind of have a head start. I think we
Yeah.
were in rural before it was cool to be in rural in doing
I was
this.
going to say you were in it before it became sort of the new buzzword.
But I think there's a bottom up approach here too. Critical access facilities may not be well versed in how does my need fit in this grand scheme of 100 million a year for a state, or an RHC is even more removed from that going, I'd love some help. I'm sitting on this cool EMR, no clue how to pop the hood on that and look underneath it. But if you raise your hand to that state office of Medicaid and the state office of rural health and say, I'm interested, there are bottom up approaches. We're one of many, I think, who have submitted applications that go, it's almost an easy button for the state.
Hmm.
Who's your service provider? What are the outcomes you want to achieve? It's got to be financial sustainability. You got to document the outcomes. reinvest those now for access to care, and then document the outcomes for improved clinical care. And we've kind of got a recipe that I would say do that. Reach out, get some funding, let your state know that you're interested. And man, that's a message of hope right now.
Yeah, for sure. I mean, give us a little commercial already. How can people, find you, track your work, learn about some of the fun things that you and the team have been working on and doing?
REDiHealth.com, REDi Health, and that stands for Rural Economic Development. We're pretty serious about this. Would just love to see rural not just survive in this, but thrive. We see a path. There is so much money that is just not coming to them that they have earned rightfully. And that's just the beginning. That helps address some of that financial sustainability. And I'd say just reach out, get on that website, look on LinkedIn, or talk to your state offices of rural health. We've done a lot with a lot of state offices for rural health the last 5 years.
John, there's been a lot in this conversation, a lot of really great golden nuggets. Just want to say thanks for being able to jump on and join. And I think when you strip it all down, rural health transformation, it's about the people who care enough to see what's really happening, and then they're choosing to build that trust where there's been doubt, and they keep showing up and after sort of the funding cycle ends. And today, just a few things that you said just sort of reminded me that data does tell a story, and when that story is told honestly, it it definitely creates alignment, and it gives leaders the confidence to act, and communities the chance to actually thrive. So if there's one thing that I'm personally walking away from this conversation, is that transformation, it starts the moment that someone decides that they want to see clearly. I mean, that's a choice. So for those, if you're listening to this, to the audience, if today's conversation moved you, or challenged you, or even just made you think differently, please, share this episode. And if there is a topic that you want us to explore, or a leader that you'd like to hear from, yeah, drop me a note, leave a comment. We take those pretty seriously. This platform is about community. It's not just about content. And just want to say, for those that are tuned in, thanks for listening. Keep building with purpose. And we'll see you next time on the Advancing Healthcare Innovation Show. Thanks for jumping on, Joe.
Thanks, Michael.